Okay, so my company is called NaNotics. I'm the founder of the company and also the inventor of the technology that I'm going to be describing, which is called nanots. And the not in the name is important because it negates a target, like the not function in computer science. This is a subtractive therapeutic. It takes things out of blood, so it inverts the drug paradigm of the last 2,000 years. So here are some of the things we've learned by participating in Space H, and big thank you to Elizabeth and Kate for including us. So we're definitely building a moon base and we're going to Mars. So the risks that I'm going to discuss have nothing to do with not doing these things. We're definitely doing these things. Also, space hazards are real, but the health consequences of those hazards are tough to quantify. Astronauts accept health risks as part of a risk package that starts with blowing up on the pad. It's the health consequences that threaten the mission that matter most. And we need better therapeutics against these mission threats specifically. So I cribbed this from Dr. Antonson's, one of his papers. This is the hazards, risks, mitigation strategies, and outcomes associated with space. And of course, a key one is radiation. And as you know, Earth is protected by the magnetosphere. That greatly limits our knowledge of the biological consequences of cosmic radiation. But we have at least quantified it, thanks to the Mars Science Laboratory, launched in 2011, which traveled for 253 days through space and landed on Mars, delivering the Curiosity rover as well as a radiation assessment detector. And that gave us pretty good information for a broad range of radiation types for transit and surface time. And this is what those numbers look like for the mission totals, surface time, transit, compared with low Earth orbit and some Earth sources of radiation. This is a logarithmic scale, so it's a little hard to tell the relative amounts. There's a linear scale. So the mission total is actually quite significant. It hits a full sievert, potentially. What matters is the risk of exposure-induced cancer. REIC becomes measurable at about 50 millisieverts. That does not mean it's important or matters. It just means that's where it becomes detectable, accessible. And if you look at the risk of exposure-induced cancer, this is the risk on top of their pre-existing risk, just being alive on Earth. The REIC for 420 days in space is about 10%. You get another 4.3% from your time on the surface. And it ends up being a total of about 14.6% for a 940-day Mars mission. These risks are elevated over the lifetime of a 35-year-old astronaut and thus pose little risk to the mission itself. Unless, that's something we're going to talk about. So I'm going to build this graph looking at a variety of factors, which we've also been discussing here. Starting with radiation, this is the cumulative radiation in millisieverts. And if you just look at that, the risk of cancer emerging and being a threat mid-journey is very low, just a few percent, at that, if that. But when you add in stress, and we've thrown in some fluctuations here roughly corresponding to mission events, you're going to see a measurable rise in cancer. How much? Nobody knows. But we do know that radiation and stress jointly drive cancer emergence. When you factor in immune competence reduction, this is a dependent variable stemming from both stress and radiation. And we have data from the ISS showing a very significant reduction of T cells, in CD8 positive T cells, which are the cytotoxic ones. And there's a really interesting paper that just came out in Immunity and Aging that describes a synergistic pathogenic interplay of microgravity, simulated microgravity, and ionizing radiation together. And what's interesting when you look at the data, you see a very significant reduction in T cells, a significant reduction in the rate of T cell proliferation, and a reduction in NKT cells on the innate side. What's interesting is you don't see this just looking at the radiation or just looking at the simulated microgravity. You only see it in the combination. Quick aside on the immune system and cancer. We think of the immune system as mainly being involved in pathogen control. It's just as an important function of the immune system to control tumor emergence and tumor suppression. The initial control of tumor emergence happens on the innate side. If you have a more mature tumor, the adaptive system kicks in. But what we're seeing here is a reduction of both adaptive and innate immune cells. So sepsis is another risk that we have to look at. I think if you just look at the probability of it occurring mid-journey, it's measurable, but maybe not too alarming. Sepsis has been a problem before. Fred Hayes on Apollo 13 came down with urosepsis. He was probably 2 days away from full-blown sepsis. When you factor in the reduction of immune competence that is likely to occur on a longer journey, you're going to see the probability of sepsis go up. I think you're going to see both of those go up in response to a rise in inflammation, which is a dependent variable on radiation. And when you factor in the reduction in antibiotic performance, both due to antibiotic resistance and the fact that the antibiotics lose potency over time, and factor in microbe virulence, you're going to see problems there as well. Also, on the inflammatory side, we know, again, from the immunity and aging study that inflammatory cytokines rise very significantly when exposed to both microgravity and ionizing radiation. So this was a really interesting paper in The Lancet, also from this year, that looked at a variety of factors related to infections in long-duration space missions. And they concluded that sepsis and infections have some of the lowest survivability, 25th among 30 conditions, and highest negative effect on the mission, first of 30 conditions. And if we put this in terms of likelihood versus consequence, we could assume that a sepsis event, all other things being equal, would have significant consequence but low likelihood. But when we factor in reduction in immune competence and all of the other aspects like antibiotic functional decline, it potentially rises up to that upper right-hand corner that concerns us the most. And same thing with cancer. Cancer mid-journey, if that had happened or were to happen, the consequence would be much greater, but the likelihood is very low. Until you factor in reduction in immune competence, and then it potentially rises to where it could occur and could be significant. So these are the risks as we see them, and the NaNot platform can address both of these risks. It's a new tool for tackling, for both tumor suppression and also for addressing sepsis. So let's talk about NaNot first principles. So historically, disease research and drug development has been very cell-centric, and that's because we've been able to see cells for 350 years since the invention of the microscope. And as a result, existing drugs are mainly antibodies that target cell surface receptors, or they're small molecules that likewise target cells. But soluble factors, meaning factors dissolved in blood or the water of tissue, are often direct mediators of disease, and therefore they're as relevant, if not more so, targets than cells. Soluble factors and cells together form a dynamic system which is dysregulated in diseases and aging. And what's particularly interesting is that by depleting soluble factors, you can reset the entire system without ever targeting cells directly. We've done it, we've seen it over and over again. The problem is that the existing drugs, like biologics, are poorly suited for soluble targets, whereas nanots are purpose-built for soluble targets. In support of our work, there's a massive body of literature on specific pathogenic soluble targets, but no way to deplete them, and nanots are engineered to solve this problem. So how do they do that? Well, nanots are fabricated using biodegradable materials and modular chemistry, which is repeatable, scalable, and safe. We start with a core. Onto that, we attach capture agents. We're transitioning from antibodies to nanobodies. Onto that, we attach a porous shield. The targets we're trying to diffuse from blood diffuse through the shield and get captured, but the shield prevents any interaction at all with cells. And that makes the nanot specific to soluble targets and completely inert relative to cells. Finally, we attach a stealth coating just to delay immune recognition and clearance of the nanot until the capture process is complete. It ends up being about the size of a typical virus, 150 nanometers across. You inject it like a drug, but it's cleared naturally by macrophage phagocytosis. We know the materials are safe, they don't hurt the macrophages. It's essentially a programmable molecular sponge, or you can think of it as molecular apheresis. And we build it using click chemistry, which was 2022's Nobel Prize in Chemistry. It makes it modular and very easy to modify to different targets and different diseases. Even though we are not yet in humans, the platform is already validated and extensible. Nanots can be rapidly developed against virtually any pathogenic soluble protein, and we've made dozens of them so far. We've demonstrated that nanots against soluble TNF, the master inflammatory cytokine, shifted mortality in a mouse model of cytokine storm. Sepsis is just one type of cytokine storm. We've demonstrated tumor suppression in multiple preclinical models using nanots against two different tumor-generated immune inhibitors. So we don't target the cells, the cancer. We target the soluble immune inhibitors that cancer surrounds itself with. Cancer can't survive without them. We've demonstrated ultra-rapid prototyping, confirmed that the shielding works perfectly, and we have a great safety profile. We haven't seen any morbidity or mortality in rodents at 100 times the planned human dosing. In terms of applications, we're going after a broad range of inflammatory diseases and cancer with significant unmet need, targeting the disease-specific soluble factors in blood. So this grid is a subset of a much larger grid that indicates how we conceptualize diseases and targets. So these are inflammatory diseases, or the inflammatory phase of complex diseases. And on the y-axis are the inflammatory cytokines that are known to drive those diseases. A huge number of diseases, these are the cytokines that are implicated. And then on the suppressive side, this is mainly cancer. All cancers are suppressive. They must suppress the immune system to survive, just like the fetus must. And we know the inhibitors involved, and that's a list of the major ones. So one of our key hypotheses is that a very small number of soluble signals or signal inhibitors drive or enable a large number of diseases. An earlier speaker referenced 10 million biomarkers. They're not of equal significance. So in the nanot world, there's a relatively small number of markers which are also drivers. That's what we're focused on. They have a disproportionate, hugely disproportionate role in multiple diseases. Again, because our chemistry is modular, it's very easy to swap a target and swap the disease. So, for instance, we can target soluble TNF, deplete that very rapidly and deeply from circulation, and interrupt diseases whose etiology depends on TNF. We can swap out that capture agent for soluble TNF receptor 1, which is an ubiquitous tumor-generated immune inhibitor. We think all tumors use soluble TNF receptors for immune evasion. You can deplete that from circulation, and that will induce migration from the tumor microenvironment. We're also developing nanot regimens for more complex diseases like MS. There are two soluble targets that are newly understood to be key drivers in MS, one on the inflammatory side, one on the suppressive side. We can make a nanot against both of these. Here's a QR code to a white paper that our team developed. These are very deep white papers. We put a lot of work into it. And I don't have time to talk about our MS strategy, so please enjoy the white paper. I'm going to move on. I am going to talk about sepsis, and we do have a white paper about our sepsis strategy as well. Sepsis has more targets involved. We can make a nanot with multiple capture agents, and you can also do multiple nanots, inject them at the same time. They don't interfere or cross-react. These are all forms of TNF, soluble TNF and soluble TNF receptor 1 and 2. We're initially focused on these because of the very large number of diseases they drive or enable. So it's been known since the early 90s that soluble TNF receptors inhibit TNF, and it has a functional role in cancer. And we know that soluble TNF receptor depletion is powerful because there's dramatic clinical data on the treatment of late-stage cancer treatment via depletion of STNFRs by pheresis. No cancer treatment on the planet works better than this. Pheresis is an invasive method of filtering the blood. Nanots are a better way of doing this in every respect, but it's still great to be in a position of developing a therapeutic where we have human predicate data from a device. So this is a clinic that operated in Germany for over a decade. They're no longer operating because the inventor of this tech had a stroke and he's no longer practicing medicine. But I've been to this clinic a dozen times. I studied with the inventor and I saw amazing things. In this clinic, they treat patients who have failed standard of care, late-stage metastatic cancer patients, via filtering STNFRs from their blood. As a monotherapy, no other treatment involved. They've treated over 100 patients representing more than 25 different solid tumor cancer types. The response rate is a 60% ORR. That's a significant response in a patient population where no response would be expected, and a 23% complete response, meaning remission. You know the Keytruda data. Keytruda is the best-selling drug of all time. It's the #1 cancer immunotherapy. We have the phase 1 data on Keytruda. It's public. Keytruda achieved just a 16% ORR and a 6% CR in its phase 1. So this is about 5 times better than that. Okay, so we made nanots against soluble TNF receptors and tested them in a syngeneic mouse model of triple-negative breast cancer, which is refractory to pretty much every treatment, including checkpoint inhibitors. And it's a metastatic model, so you're looking for a delta of metastasis. In the nanot cohort, there were 5 times the number of metastasis-free survivors compared with control, and a mouse equivalent of Keytruda, an anti-PD-1 antibody. So nanots against STNFRs induced tumoricidal immunity in metastatic TNBC. And we're collaborating with Mass General on this under Keith Flaherty, who's kind of legendary in cancer immunotherapy. And here's our white paper on STNFRs. I know what you're thinking. If STNFRs are such a great target, why has nobody made a drug against them? And the answer is it's an undruggable target. A drug against soluble TNF receptors would also bind and block membrane TNF receptors. That pathway must be kept open because it's the cornerstone of immunity. So no one has ever drugged this target, no one ever will. But nanots can deplete STNFRs without blocking membrane TNF receptors, and that's one of the nanot advantages compared with antibody drugs. They're also very fast. Nanots will deplete any soluble target they're programmed to deplete by greater than 95% in less than 5 minutes. Contrast that with pheresis, which takes hours and can't hit that level of target depletion. Okay, so another oncology target that's quite significant is soluble PD-L1. So soluble PD-L1 is just the soluble form of membrane PD-L1. And in the oncology world, PD-1 is an inhibitory receptor on immune cells. PD-L1 is the protein that ligates or activates that inhibitory receptor. This team at Mayo Clinic actually believes the soluble form is doing a lot of the heavy lifting of immune inhibition, commonly attributed to membrane PD-L1. And their team includes the co-discoverer of PD-L1. So we made nanots against human soluble PD-L1, turned them over to Mayo Clinic, and they tested them in humanized mice where the immune cells have human PD-1 on them and the tumors have human PD-L1 on them. And nanots profoundly suppressed those tumors. Mayo wrote a paper, Depletion of Soluble PD-L1 with Engineered Nanoparticles Promotes Anti-Tumor Immunity. Immunity here is an interesting word. You can actually replace that word with resilience. And in the Mayo studies, they did some really interesting work on immunophenotyping. So they looked closely at how the cells in the tumor microenvironment changed. And what's interesting is that the ratio of T effector cells to T regulatory cells was more than twice as high in the nanot cohort than the control cohort. So T effector cells are the cytotoxic cells. You want them to be at a maximum. T regulatory cells promote a suppressive environment in the tumor microenvironment. You want them to be minimized. What this means is that a cellular transformation was achieved solely by depletion of soluble targets without ever targeting the cells directly, just by taking something out of blood. So let's talk about sepsis. Sepsis is an immune system overreaction. There's no effective treatment for sepsis. It's the #1 cause of death in hospital. Nanots will be the first purpose-built injectable therapeutic for sepsis. So here are the targets involved. You don't have to tackle all of them to make a big dent in sepsis. Sepsis is part of a cascade. It's generally triggered by some sort of pathogen, wound, even stress can trigger it. There's a rapid uptick in TNF-alpha, the master inflammatory cytokine, followed by IL-1 beta. This leads to a spike in IL-6. That does most of the damage, most of the cellular damage. 35% of sepsis patients die in the first 4 weeks from this inflammatory phase. But there's a second phase, which is immunosuppressive, which presents like HIV. Another 35% of sepsis patients die in the first year, and we know the suppressive factors involved. We can take those out just as easily as we can take out the inflammatory factors. And the suppressive factors overlap with cancer, as you know, that would make sense, right? So we're building a regimen, a cocktail against these inflammatory factors, and one for the suppressive phase. You could just focus on the inflammatory phase and save millions of people that way. But if you want to really comprehensively tackle sepsis, you have to tackle the immunosuppressive phase as well. So here's our pipeline. We're developing a broad range of nanots against these key targets. We'll have a whole pipeline set up by 2030, in time for Mars. They'll all be through phase 2 by then. The first 3 of them are against inflammatory targets. The next 3 are against suppressive targets. And then we're doing combinations both for MS and for sepsis. So how will nanots be administered in space? Well, the technology exists right now. Astronaut Tim Peake here in 2016, he did blood draws in space. It's done routinely. And this is him filling a sample tube, loading it into the centrifuge to separate out the cells to get plasma from it. You can analyze blood in space too. This is a multiplexed ELISA called the bioanalyzer. You just put a blood sample into it and it quantifies specific proteins in minutes, and the results get transmitted through ISS comm system. It's not the most accurate thing. It's accurate enough. There's much better stuff coming. It doesn't have the breadth of tests that we might like to see, and there are no therapeutic recommendations. But here's what's coming. Microfluidic devices, you put blood into it, you load this into the multiplexed ELISA. This is an imaginary Scott Kelly analysis showing that his tumor-generated inhibitors are elevated, and it actually recommends not just the nanots to use, but their dose as well. So we have a broad range of patents, which I'll just skip through. Foundational US patents, 29 foreign patents. We hope to have some Mars patents when those become real. And thank you very much.